Good morning, good afternoon, good night, wherever you are. We're very happy to have you here to this ATS VIPPN clinical cases. Today we are going to have two very interesting cases. The first case will be presented by Dr. Ece Gürbüz from Manisa Celal Bayar University, from the Department of Pediatrics, and it will be discussed by Dr. Hasan Yüksel from the same department, and then Dr. Zehra Nur Töreyin from Ece University, and Dr. Merter Keçeli from the Aydın Adnan Menderes University Medical School from the Department of Radiology in Turkey. After that, we will have the second case that will be presented by Dr. Zeliha Başak Polat from the Istanbul Medeniyet University Department of Pediatric Pulmonology, and will be discussed by Dr. Sinem Can Oksay from the same department in Turkey. So thank you very much to all of you to be here, so we can start now.
I will be presenting a case with the topic of emerging problem in working children and pulmonary involvement in occupational diseases. Okay, our patient was a 14-year-old boy who had a history of fever, vomiting, diarrhea for 10 days, hemoptysis for 3 days, which regressed with upper respiratory tract infection treatment, and back and lower pain for a year. He also visited an ENT specialist for a headache complaint, which later on was ordered in cranial CT. On the CT scan, there was sinusitis, and the patient was treated with clarithromycin for 3 days. He also had a 9 kilograms of weight loss over 10 days. On his social history, he used 1 to 2 hookah per week for a year. He had a 3-week history of e-cigarette use for 2 months, 1 week history of cigarette use for 1 month. He also was a student in a vocational high school and works at construction site 4 days a week. He installs air conditioners and straightens metal pipes using a flame-based power source. On his past medical history, he was a term delivery. He had no history of hospitalization and had no history of pulmonary disease or treatment. On his family history, his mother was a 38-year-old with no known medical conditions. His father was a 45-year-old with thalassemia trait. He had a sister who was 19-year-old with no medical conditions. His cousin was a 17-year-old with hemophilia A, and there was no tuberculosis cases and no index case in the family history. On the lab findings, which was on the December of 2025, there was only mildly elevated CRP levels prominent, and the other findings were in the normal range. On his chest X-ray in the December 2025. Okay, these were the findings. On his follow-up, he was admitted to the pediatrics ward and was treated with empirical cefuroxime. And on his December 2025 thoracic CT angiogram.
Yeah.
Dr. Keçeli, yeah, thank you.
Could you run this CT,
Yes,
please continue? Okay, thank you. Intravenous iodine-based contrast medium was administered to the right upper extremity and thoracic CT scan was obtained. Both hemithoraxes are of equal width. Areas of air entrapment. Oh, yeah. This is mediastinum phase. There are nodules with reactive millimeter size lymph nodes. In the mediastinum, there are no calcification or suppuration. The heart and major vessels appear normals. There are filling defects in the wall of the superior vena cava. Could it be thrombus remnant? I don't know, sure. It doesn't not extend to the heart. Yes. Yes, it's maybe, okay. Both extremities are equal. You can see thickening ground glass opacity in the posterior segments of the right lobe, upper lobe, and all segments of the lower lobe, indicating inflammation in the peribronchial areas. Areas of bronchiectasis are visible within the infiltration on the left. Yeah, there is thickening of the interlobular septa in subpleural space in the left. There are areas of consolidation in the peripheral space. An arcade sign is seen in the periphery. There are nodularities are thickening in the adjacent pleura. Pleural thickening accompanies this appearance in the right basal area. Subpleural millimeter size density in apical segment of the, again please, okay. In the right lower lobe may show atelectasis. There's ground glass opacities in the and wall thickening in the right lower lobe, indicating peripheral bronchial infiltration. Nodules with ground glass opacities in the subpleural areas of the right lower lobe. Yes, there is no pleural fluid. According to the findings, possible diagnosis of radiology, hypersensitivity pneumonitis non-fibrotic phase, and given that he was engaged in welding work, chemical-induced lung injury due to toxic gas inhalation, or cryptogenic organizing pneumonia. That's all. Thanks.
On our differential diagnosis, our diagnoses were pulmonary tuberculosis, hypersensitivity pneumonitis, or occupational disease, which was related to toxic inhalation exposure. On the additional lab findings, his PPD was 5 millimeters with BCG scar. Brucella serology was negative. Hepatitis serology was negative. Fecal occult blood test was negative. And his sputum culture, there was no growth. Interferon gamma release assay test was negative. Also, the fasting gastric fluid collection over 3 days. Acid fast bacilli, mycobacterium PCR, mycobacterial culture were all negative. His follow-up X-ray, chest X-ray findings. He also had a flexible bronchoscopy. The findings were edematous mucosa, increased airway secretions, vaccine nodules in submucosa, and tracheomalacia. Yes, I'm continuing. On his bronchoalveolar lavage, there was no specific culture growth. The acid-fast bacilli, mycobacterium PCR, and mycobacterial culture were all negative. Our diagnoses were chemical pneumonitis, which lead to toxic inhalation. In his follow-up, elimination from work environment was recommended, and he was on inhalated steroids.